So, good morning and good afternoon. My name is Tim Devling, the Director of Sales and Applications at iTheraMedical here in Munich. I want to welcome and thank you for taking the time to attend this webinar on optoacoustics for innovative preclinical imaging. The webinar will last for around 40 minutes with time for questions at the end. Should you have any questions, if you maximize the Go-To tool, you can see a question box where you can type them. We'll also be recording this webinar and we'll send you a link to view after the event. So this will be a summary of research performed by users of our MSOT and RSOM technologies, and I welcome to give the presentation my colleague, Dr. Neil Burton. So over to you, Neil, and thanks.
Okay, thank you, Tim. I hope you can hear me just fine, which would mean everybody else could hear me as well. Thank you for the introduction. So my role at iThera is I'm the team lead for applications. And in this presentation, I'll be focusing on how optoacoustic imaging can be used for preclinical and clinical research, as Tim said. We all know that funding continues to be a challenge in today's competitive climate. I was doing some research this week and on the NIH website, and for all submitted applications, fewer than 20% are accepted, but for some particular grant calls, the pay line is closer to the 10th percentile. So it's certainly a competitive environment. And at least I believe that optoacoustic imaging could be a good option for competitive submission these days. There's a proven history of translational studies from mouse to man with a wide array of applications, which I'll talk about, demonstrated by researchers around the globe, more uses and reach than just what I'll talk about today. The resolution and depth, as I'll talk about today, are scalable, and this gives researchers flexibility and versatility and also new avenues for successful grant submissions. So just before I begin, I'd also like to also second what Tim said and just say thank you to everybody who's joining. I know it's 4 o'clock here in Munich, but I know it can be very early for some people and very late for others. So I'd just like to say thank you for not only registering, but signing up today and joining. Thank you. So in terms of preclinical imaging, there are a lot of different options for people to use at the moment. There's a lot of technologies that are available. Some are new, like MPI, magnetic particle imaging. Some have been around for decades, literally. MRI, PET, SPECT, CT or micro CT. There are other options. Optical imaging is represented here by BLI, bioluminescence, and fluorescence imaging. Today, obviously, I'm going to be talking about optoacoustics, which is also known as photoacoustics. These terms, if you're new to this field, these are completely interchangeable. And of course, ultrasound. So in terms of preclinical imaging, we're all spoiled for choice. And then when it comes to the individual sections, although I don't want to spend too much time on this, there are a lot of options in the field and even more in the clinical space. And so the real question that I'd like to address in the webinar today is, if you don't have optoacoustics in your facility now, why should you? I hope in the coming slides in the next 35 minutes or so, I hope to give you a compelling argument as to why optoacoustics could be right for you as an addition into your imaging program. If you are considering bringing in new equipment, there are challenges when bringing in new equipment. There are multiple things to think about both in terms of usability and management of a system, especially if, for example, you might be either managing, using, or participating in a core facility. On the usability side, you have to think about whether the technology is something that can be easily taught to somebody. So my expertise is not PET or MRI, but I also am quite aware that that would not be something that could be easily picked up in a day or two. This is something that you really need to sit down and learn. And likewise, every different modality has different requirements for data analysis, and these are things that if you want to bring in a new technology and you want it to be used, the data that is the output that has to somehow be manageable for the users. This is a balancing act as well, especially in something like a core facility in terms of management. So core facilities have a lot of different types of equipment in them, as suggested on the previous slide. So it can be difficult to make sure that the staff who might be working there is knowledgeable about all the different equipment. The operational cost for some systems can be considerable, and it's definitely something to think about. And at the end of the day as well, you need a system that actually works. So you have to think about maintenance too, and potential downtime and what you can do to mitigate that. So there's a lot to think about, both in terms of the use of the system and managing it, but none of that really matters if the system itself doesn't have some kind of value, not only to the researcher, his or herself. I mean, it has to be a positive experience when this machine or device is being used. There has to be value for the scientific community at large as well. They need to trust in that technology. They need to respect and value the technology that's coming out. And ultimately, the aim of many researchers is to have high impact factor publications as well. And this all feeds into essentially doing what is important to a lot of people, which is getting grant awards. So at the end of the day, when we're presenting or publishing papers, we do need to secure funding to keep our research going. So this is all very important in terms of deciding whether or not a new technology should come into your facility. One thing that I thought about in preparation for this webinar is I had a look at publishing trends to figure out what users are currently using these days. And the way that I did that was to look at the average publications for a particular modality over the last 5 years to come up with an annual average, and then compare that to the number of publications that came out last year for that particular modality. So if a modality is being used less, then here that's represented with a negative percentage. So in the case of MPI or CT or micro CT, there were approximately 30 to 40% fewer publications last year than what the average was in the last 5 years. Some modalities were pretty stable, meaning plus or minus 10%. So that includes some of the staples like MRI or PET and ultrasound as well. There was, let's say, a moderate decrease with SPECT, but it was pretty close to the 10% line, and a moderate increase for optical as well. But I thought what was surprising when I looked at it this way is that there was a nearly 30% increase in optoacoustic publications. So it's a technology that researchers want to use right now and that they're getting value out of. So I think that's something important to consider if you're considering adding optoacoustics to your imaging program. I wanted to talk a little bit about the mechanism of how optoacoustic imaging works. I was looking at the attendees of the webinar today, and it very well could be the case that optoacoustics is new to some of the attendees. The video that should play here, which I'll pause from time to time. What we see here is an investigator, in this case. This is a clinician who has a system in the University Hospital in Erlangen here in Germany, Max Waldner. I show some of his work later on today. He's using one of our devices here, the MSOT Acuity, on a patient who's lying on a bed. You can see him interacting with the screen. But the way the technology works in this case, if I pause this at the right moment, I missed the light pulse there. But the handheld detector in this particular case, or it could be an animal scanner, which operates very similar to PET or MRI, where we translate an animal through the imaging plane. But what would happen in either case is a pulse of light comes from the detector, and this shines into the tissue. The light then gets scattered and illuminates a particular region of interest. Then molecules within the tissue absorb this light. Those molecules could be those like hemoglobin, melanin, collagen, lipid, could be an injected contrast agent, so long as it absorbs in the range of the laser. For the most part, we're using near infrared light for illumination, but that light energy needs to be absorbed by something in the tissue. And then what happens is the molecules become excited. And this is a very common phenomenon that people understand from optical imaging. And the exact same thing happens here. The molecules go from a ground state to an excited state, In the case of traditional optical imaging, where you have optical excitation and optical detection, then you're detecting a photon that's emitted. We don't see those photons, so as long as something absorbs light, whether or not it emits a photon or not, that we don't see or really care about too much. But what happens when the molecule relaxes from the excited state back down to the ground state, there's a small amount of heat that's given off because this process is not a perfect process, and a thermoelastic expansion is created around that molecule, and that makes a spherical pressure wave. And we detect that by using an ultrasound transducer. And that's what's depicted here by this cartoon with these spherical waves. You can then translate the probe. Here we're seeing a particular, if I just back that up a little, pause at the right time. But in any case, in the handheld case, we're using an array of transducers, a hemispherical array that might have something like 130 degrees. In the animal case, we would have a bit more coverage, 270 degree array, and other applications may use more or less detectors or different shapes, and I'll get into that a bit later. Just move on. Once we've acquired a particular cross-sectional image at any particular wavelength, the single image that we get as a resulting 2D image, this would be the result of a mouse image, what we're looking at here. I'll show a larger version of this later, but we're looking at a cross-sectional image of a mouse at the level of the kidneys. And for each of the individual wavelengths that we use to excite the animal, we get a single grayscale image that represents the composite amplitude at that particular voxel. We then consider that to be a stack of images, and the particular wavelengths that we would acquire, the laser that we use is tunable in 1 nanometer steps, so the user has a choice as to which wavelengths would be used to acquire the data. In choosing those wavelengths, we could consider the spectrum in the middle of this slide. We see 3 spectra in this case. The blue is deoxyhemoglobin with a local minimum at 730 and a local maximum at 760. In red, we see oxyhemoglobin, which is monotonically increasing over the range of these wavelengths. And we also see IR dye 800, which has a peak absorption in this particular graph at 780 nanometers. So we would choose wavelengths that would discriminate these chromophores, and that would allow then our algorithms to do the best job of spectrally decomposing the relative contribution of those absorbers. And the way that works is if you consider a single pixel in our stack of grayscale images, all we measure is a composite spectrum. So we then tell our software that these 3 particular spectra that you see in the middle could be in the field of view, and then it calculates what relative contribution of those 3 different spectra could give rise to that composite spectrum. In a nutshell, that's how spectral unmixing works. It can be complicated by things like fluence, which means that you have less light that would be available to produce absorption at depth than you would superficially. But we do have ways to cope with that. For example, fluence correction, which can be done in our software. But this whole process allows us to go from single wavelength grayscale images then to absorber images, which represent functional or molecular information. In blue, now I can see the relative distribution and quantification of deoxyhemoglobin. In red, I see oxyhemoglobin, and then in green, I see IR dye 800. In this particular experiment, a dye was injected that would filter through the kidneys, and these 2 hyperintensities that we see on either side of the image represents the renal pelvis of the mouse as this dye gets filtered. To show these kinds of images a bit larger so you can appreciate where the contrast comes from, we look at the image on the left. This is what a single wavelength image would look like. Where the pixels are white in this case, this represents areas of high absorption. So give the predominant absorber in a mouse is hemoglobin. So these are small blood vessels or well-perfused organs. So on the left at 9 o'clock, I can see the spleen very clearly. I can see next to that the left kidney, and on the other side the right kidney. I can see the aorta, the vena cava, the spinal cord, and so on. So just with optoacoustics alone, due to the fact that we use tomography and we have detectors placed around the mouse, we can see a lot of anatomy within the animal. It's also possible, though I'm not showing it in this case, that we could also use our detectors in transmit and receive mode so that we could also have a tomographic ultrasound image. So we have the option to show different kinds of contrast. The next step that we would do in this case, we would eliminate the signal outside of the mouse because this may not be relevant. We then do, as I said before, if we are interested, fluence correction through our software and spectral and mixing. We then take one of those single wavelength images for the anatomical reference, and we overlay on that, on top of that, either the functional or molecular information that was derived from the spectral and mixing. If we move to the third panel, then we would see what we would do as a last step, which is to get as much information out of that anatomical image as possible. So then we would do some image filtering on that. And the reason we would do that is that the source image that we have on the left, this is acquired using a broadband transducer. So using frequencies from 50 kilohertz to 7.5 megahertz. So this is detecting both large and small structures. And when we try to present all that information at the same time, some of the structures get muddled. And so when we do this kind of background image filtering, we can really bring out some of the high resolution information that would otherwise be lost. We don't quantify these filtered images, but they do help with anatomical localization. In terms of functional imaging, this phenomenon is probably well known to this audience, so I won't spend too much time introducing it, except to say that through arteries, veins, arterioles, venules, and bulk tissue, hemoglobin is transporting oxygen throughout the body. As oxygen is needed, then these oxygen molecules will come off of hemoglobin, and then the hemoglobin will become less oxygenated. And the reason we can detect that is that, as I showed on 2 slides ago, the oxy and deoxyhemoglobin have distinctive spectra. So just as would be done in bold with the sensitivity for deoxyhemoglobin, we can detect not only HbO2, but also Hb, and that allows us to see not only these chromophores, but calculate oxygen saturation, total hemoglobin, and present that either as an image or a quantified value. What some users have done, and this is what I'm showing on the right, this is coming from the Cambridge lab from Sarah Bondic, who was formerly at Stanford. And what she's done is to, let's say, challenge the animal in some way. This came from a paper where she was looking at tumors, but this can be done in other cases as well, where she would challenge the animal by changing the kind of inspired air that the animal would get. So starting out with what she's calling air in this case, which is 20% oxygen, changing that to 100% oxygen, and then seeing a shift in that baseline. And either based on the time it takes to go from one baseline to another, or to look at the magnitude of difference between those 2 baselines, which is what they call delta SO2, we can derive metrics on a per pixel basis that can tell us about tumor heterogeneity, can tell us about response to therapy, and so on. Due to the use of a multispectral laser, we can also see contrast agents with MSOT. We see different classes of contrast agents, as indicated on the cartoon on the left. We can see quite clearly conjugated plasmonic particles. So this would include a gold nanorod, for example. This is a very commonly used contrast agent, at least in the preclinical space. But it's not the only kind of nanoparticle that we can see. In fact, we can also see carbon nanotubes and quantum dots, as long as they have the right shapes and sizes. We can also see agents that are used in non-optical modalities. Just to give a few examples, for example, something that was used in MRI a few years back, there were a couple of papers that used melanin as a multimodality contrast agent that would be visible in both MRI and photoacoustics. But this is also possible with ultrasound, because since we have the ability to do transmit and receive with our transducer elements, we can also see microbubbles. There are many organic dyes that are commercially available, and a lot of these can be conjugated to peptides or antibodies for targeting. And there's a variety of those that are available, as well as injectable chromogenic substrates that can be enzyme activated, and very closely related would be smart probes that would change their structure and potentially then their absorption spectrum as well, so that we could evaluate a particular state within the animal. And then finally, another source of contrast would be a genetic reporter. So the normal range of the laser, as I mentioned before, that we use is in the near infrared window, but there are some fluorescent proteins, the IRFP proteins, that absorb in this range that allow us to get contrast in particular models. In terms of what it takes to generate an optoacoustic contrast agent, this is summarized on the table on the right. There are some things that are in common with any probe production process. You're looking at the ease of synthesis or conjugation, the cost, size, and solubility. Biocompatibility and bioavailability are always important, as are the binding and stability. The one thing that really stands out in the optoacoustic space is the photoacoustic energy conversion. This is probably a concept that's very well known to people who do optical imaging, because we know about a quantum yield, how much of the absorbed light energy is then transmitted into emitted energy. This is not exactly what we detect in optoacoustics, but rather we see something that is analogous to an inverse of the quantum yield. So we don't care about how much is emitted. We're actually more interested in how much is not emitted, because that means more of the absorbed energy is being translated into heat. And this is, for example, what makes the conjugated nanoparticles like a gold nanorod very appealing for optoacoustics, because they absorb light, but they don't emit at all. So they're very good absorbers. And as I mentioned before, I wanted to talk a little bit about the scalability of optoacoustics. So to introduce this topic, I wanted to talk about scalability of in vivo imaging in general. I took this particular image from a review from 2018. What we see in the middle is photoacoustics and OCT paired together. But what we see in this case is that there's a range of spatial resolutions. It's kind of centered in this particular case on 10 microns. It really does go into the hundreds of microns. That was a particular implementation they're talking about there. But you can see how it stacks up against MRI, PET, and SPECT, and CT, and so on. In terms of molecular sensitivity, the advantage with optoacoustics is that there's an enhanced sensitivity as compared to, for example, MRI or CT. But when you compare to something like PET or some cases of optical imaging, for example, if there's a superficial target in optical imaging, then the background is very low, scatter is very low, and you can have very high sensitivity. But as you go deeper into the tissue, this relationship changes a bit. But then we also consider depth. And so here we can see that the range of depths in optoacoustics is ranging from the millimeter range to the centimeter range. So clearly all the imaging modalities with these different relationships, they all have their time and places to be used. Certainly photoacoustics is never going to replace whole body human imaging with MRI or PET, but it certainly has its own characteristics that make it suitable as a complement for these other technologies. If we consider the scalability of photoacoustics in a bit more detail, then we can consider that that the optoacoustics can be separated into three regimes based on spatial resolution. One is microscopy. This is well known to everybody. Everybody's used a microscope. The next or the last stage is macroscopy. So this is where resolution would be in the hundreds of microns range. In between there is something we call mesoscopy. So resolution in the 10 to 20 micron range. And what we can see in this case is that as you might understand from many other imaging modalities, as you increase the imaging depth, then the resolution gets worse. If you want to have 3 to 5 centimeter depth with optoacoustics, then you'll be using ultrasound transducers that have a center frequency that are going to give you resolutions maybe in the 150 micron range. If you're interested in resolution below 5 microns, well, you're not going to get very deep. If I just skip the animation here, and I'll be talking about muscoscopy soon, but here I'm now dividing the systems that we actually have that are available for people to use, in dividing those between preclinical and clinical devices. So when it comes to microscopy, there's 2 types. Optical resolution photoacoustic microscopy and acoustic resolution photoacoustic microscopy. These are things that people are using as, let's say, home-built systems or systems that they use in their lab. To my knowledge, there's not yet a commercial version of this available, and it's also, to my knowledge, not yet being used widely in the clinical space. When it comes to muscoscopy, however, we have 2 systems that can be used in this regime. We call them the RSOM Explorers, either a P50 for the preclinical or the C50 for the clinical. The 50 describes the center frequency of the transducer that's being used. So it's a 50 megahertz transducer that sees frequencies from 10 to 100 megahertz, which gives us a resolution down to 10 to 20 microns. And as you can see from these images, there's one version that has an arm that makes imaging of patients in a research setting very easy. And there's a second version that has an enclosed box into which you could put an animal. In the macroscopy regime, we have 2 products. The preclinical version is called the MSOT Envision, and the clinical version is called the MSOT Acuity. The Envision, as I briefly described before, this has a transducer that stays in place, and then we have a mechanical stage that will drive the animal through the imaging plane. So it's very similar to PET or MRI. For the MSOT Acuity, or for a hybrid Envision case, we connect handheld probes to these so that you can do handheld imaging, and I'll show some examples of imaging in just a few minutes. So when it comes to iThera's version of optoacoustics, I'd just like to briefly talk about a few key scientific benefits of our version of this technology. So the first point being, and this is my opinion, but I believe that we're leading the field of optoacoustic imaging, in part because we have the broadest product portfolio, but also because we have high performance product, worked with global key opinion leaders, and based on the journal impact factor of publications that our users are publishing, very strong scientific output. We have a superior optoacoustic image quality, and this is because that we've employed tomography in order to build a version of this technology that puts the optoacoustic image first. That comes in some cases at a cost of, for example, ultrasound image quality, but we really strive to produce the best possible optoacoustic image. Due to the fact that on the preclinical side, we're using a motorized stage, as I talked about, this allows us to do whole body imaging, full cross sections I've already shown, and you can really image head to tail in a repeatable position, either during one imaging session or, as some users have demonstrated in publications, over days and weeks. Also allows us to do 3D reconstructions at the touch of a button. We have a very high molecular sensitivity as compared to other implementations in the field, and this is due to the fact that we use a very large detector surface area, and sensitivity is directly proportional to the size of those detector elements. And again, we've built our detector in order to maximize the optoacoustic image quality and sensitivity. And in addition to that, we're using low noise electronics. We build our systems and optimize them here in Munich. So we're constantly trying to optimize things like that. As I'll show in a later section during this presentation, the imaging is truly translational from the Envision to the Acuity, or within the Explorer series. You can really drive one model from bench to bedside. And as I'll show in just a minute, there are proven preclinical and clinical applications with high impact publications. And because we have the RSOM Explorer, we have a unique option for high resolution imaging with photoacoustics. And we have the only commercially available high resolution system, and it also has a multispectral option. So I want to, now that you know a little bit about, we're on the same page about how the technology works, I wanted to talk a little bit about what it can do. So I prepared this slide, which gives an overview on the different types of biological processes or pathophysiology that is, has been demonstrated already to be detectable by users in the field, not just users of iThera's equipment, but really all the users of photoacoustics in the field. And this doesn't necessarily reflect everything that's possible. It just shows what has so far been proven. I've divided these processes into different categories. The first one is cellular dysregulation. On that topic, people have used this technology to look at apoptosis, angiogenesis, oxidative stress, inflammation, and upregulation of different receptors on the cell membrane. Then the technology is also used to look at changes in tissue in terms of, for example, infiltrating T cells or macrophages that might infiltrate into a tissue when damage occurs. An early sign of injury or disease could be hypoxia, and certainly in some cases there's a change in lymphatic flow that is detectable as well. There's, in terms of disease or injury, their effects can be, that are detectable by optoacoustics, can be divided into two parts, both acute and chronic. On the acute side, we're talking about things like ischemic injury or organ function, infection or fat metabolism. On the chronic side, the technology is sensitive to things like fibrosis and neurodegeneration. Not all neurodegeneration, but specific subtypes that I'll get into later. And then finally, some researchers have used this technology to look at interventions in specific disease contexts, both in monitoring tissue ablation. So for example, in cardiac muscle ablation, it's necessary to ablate particular parts of the electrical pathways, and you want to do some damage but not too much, and this can be monitored in real time with this technology. And with the different endpoints that are possible with the technology, it's also possible to look at therapeutic efficacy by looking at things like oxygenation or changes in cell receptors. So I want to, given that the audience for today in this webinar is very broad, I wanted, in some cases new to this field, I wanted to give a very broad overview about what specifically, which applications people have used this technology for. I don't want to go into too much detail on any one of them, but if you're interested, if anything here catches your eye, you can certainly follow up with us. We'd be happy to send you either a paper or schedule a second call to go over some of the details about what I'm going to talk about now. But if anything catches your eye, just make a note and we can certainly talk about it later or in the question and answer session at the end. For all the applications that I'm going to show, I divide the, say, mechanism of contrast for those applications in terms of a color code. So applications that are derived from looking at hemoglobin are in blue, those that use contrast agents are in dark gray, and then in the lighter gray is lipid, collagen, or melanin. So the first application area that makes a lot of sense for optoacoustics because we're sensitive to hemoglobin is the vascular system. And in that regime, people have looked at peripheral vascular disease, vascular malformations, brown fat metabolism, angiography, and thrombosis. In this particular case, most of those studies were done in the clinical context. But preclinical researchers have also used contrast agents to look at atherosclerosis. This is also of interest in the clinical space, but so far not very well worked out. Moving on then to the lymphatics, people have actually used in a preclinical model drainage of ICG from the eye as a surrogate marker for intraocular pressure in glaucoma models. Obviously then when we're talking about lymphatics, you can then use contrast agents like ICG or methylene blue to identify in patients with cancer which lymph nodes could be the sentinel. This then gets into cancer applications, which I'll cover next. But in many cases, you might want to look at lymph nodes either in that context or in the lymphedema case, where clinicians may need to visualize lymphatic vessels ahead of surgical intervention so that they know how to plan their studies or their surgery. This can be done as well with optical imaging, although in that case it can be difficult with dermal backflow to see underlying lymphatic vessels. There was a publication on this just a few weeks ago. In terms of skin, there's a lot of different things that can be done. Because we're talking about skin, a lot of these applications are based on the RSOM Explorer, which has the high resolution with less depth in the millimeter regime. But in this case, people have done quite a lot of things. I think this month was meant to be a presentation at a conference in Toronto looking at port wine stain therapy with laser therapy. I think that conference got canceled, so we're waiting for that to be rescheduled so we can follow that work a bit more closely. I saw at a conference last year, users also using the optoacoustic technology to look at eczema treatment, and published a few years ago now. It's also looking at psoriasis treatment using the RSOM Explorer. But people have also looked at treatment of inflammation, looking at different hemoglobin endpoints to track how well a particular therapy is working. People have also used the sort of macroscopic optoacoustic approach to look at burns and ulcers on the skin and track how those heal over time. Some researchers in both the clinical and preclinical space have also used this technology to look at scleroderma and systematic sclerosis by looking at oxygenation endpoints that change with the severity or the time course of the disease. And the same is true as well with atopic dermatitis. In terms of alopecia, users have also used this technology to look at not only hemoglobin, so looking at the vessels around a particular hair follicle, but the hair follicle itself. A lot of times what people would do is pull a hair follicle out and gauge, for example, its stage in the growth cycle. But for somebody who is losing his or her hair, this kind of pluck test or a biopsy, this is not, let's say, the favored way to go, but rather something non-invasive would be a bit more interesting to those patients. So there's different approaches there. And in the preclinical space, people have used multiple labs, dedicated contrast agents in either dyes or nanoparticles to look and track infections over time in subcutaneous models. Next, researchers have used this technology in gastrointestinal diseases. I'll talk more about inflammatory bowel disease in just a few minutes. This one is very interesting for us, but also in terms of drug development, gastric emptying is very important because intolerance of drugs is a very common side effect for drugs, and this can be tracked with optoacoustics. In terms of brain imaging, looking at hemoglobin and looking at functional imaging within the brain, there's a lot of different things you can do with that, both in terms of looking at drug-induced changes in activity or somatosensory changes in activity after stimulation. The same approach is used to look at epilepsy as well, so you can track those events in real time. And oxygenation was also looked at to track the degree of neuroinflammation. As I said earlier, neurodegeneration is on the list as well. And in this context, I was talking about Alzheimer's disease. This has been done now by multiple labs, either with contrast agents or just looking at oxygenation. And the same is true either for stroke or ischemia, where they look at the size of the infarct based on oxygenation patterns in the brain. And then some users have also used optoacoustic imaging, not using our system, but using a laser in the visible range to look at calcium sensing so that they can see events that would be leading up to action potentials. People have also used this technology to assess the liver, both in terms of hepatotoxicity by looking at rates of filtration of different dyes out of the blood, where these dyes would be filtered by the liver, but also by looking at collagen. People have looked at the extent of liver fibrosis. In both of these cases, these were done in preclinical models. Similar to the approach for hepatotoxicity, dyes that filter through the kidney can be used to look at nephrotoxicity. Some researchers are interested in looking at the joint, whether it's inflammation in the joint itself, in terms of synovitis or arthritis. And this can be done by looking at either hemoglobin signals or with injected contrast agents, as well as infections in the joint. In terms of the spinal cord, some researchers have looked at nerve and vascular hemodynamics, and by looking at lipid deposition, white matter loss. In terms of muscles, both ischemic injuries, and as I'll talk about in just a couple of minutes, muscular dystrophy was tracked using this technology. In the developmental space, the placenta and the embryo can be visible in preclinical models, and so looking at oxygenation can reveal what's happening in the placenta. Cardiac applications, as I alluded to before with ablation, are within reach, and using contrast agents, some researchers have also looked at myocardial infarction. And finally, lung is not let's say the best target when you're looking at acoustic detection because of changes in speed of sound with air. Some researchers have used the pulmonary transit time of dyes that go between the heart and the lung to derive surrogate markers that correlate with pulmonary hypertension. So those were non-cancer applications. I have just a few cancer applications as well. What I want to get across here is that a lot of different organ systems that have cancer have been evaluated with optoacoustics, both the brain, the eye, and lymphatics, in terms of evaluating, as I said before, which nodes are the sentinel. And then once they identify those sentinel nodes, they can evaluate, in the case of, for example, melanoma, whether or not metastasis has occurred. In terms of skin, there's quite a bit of therapy applications that have been used: radiotherapy, chemotherapy, photodynamic therapy, and oncolytic viral therapy. And the approach has also been used to detect the status of skin lesions. Melanoma is an obvious choice because it's dark and very absorbing, but also researchers have used optoacoustics to assess basal cell carcinoma. And last but not least, some researchers are using this technology to look at the microenvironment, whether it's immune cells coming in, or the pH, or small vessels during the process of angiogenesis. These are all things that have been looked at in the cancer context. In terms of the liver, preclinical models have shown detection of lesions in the liver. The same is true with bladder in preclinical models. And both on the preclinical and clinical side, breast lesions have been both detected in living subjects. So there's the largest clinical study ever done actually was done in 2,000 patients using optoacoustics, not our platform, but another. But the point is that this technology is now being used, let's say, with large clinical trials. So I think that's a very exciting advance for the field of optoacoustics. But in terms of also assessing in a surgical setting the margins for lumpectomy. So this has been done in a few studies by now. In terms of fat, as fat itself is absorbing in the range of our laser, lipomas can be assessed. In preclinical models, researchers are also looking at pancreas cancer, prostate cancer. In this particular case, in the prostate, the approach that I'm aware of was done on samples that were evaluated after surgical resection. Thyroid is also being evaluated with photoacoustics to differentiate malignant and benign nodules. Preclinical models are also looking at ovarian cancer, both in terms of looking at oxygenation, but using contrast agents. And then finally, gastrointestinal disease is also being assessed in preclinical models. So what I'd like to talk about next is a bit of the translatability of this technology. iThera has been around for 10 years by now. So when we first started out, we just had preclinical options. At one point in time, this is a picture of me actually next to my colleague Elena, but we had a transitional product which we called the MSOT IP, which was letting us do initial clinical studies. But then in 2015, we launched the MSOT Acuity, followed by a couple of years later, just last year, we got our first CE mark for the MSOT Acuity with a technical intended use to be used as a medical device here in Europe. We have planned for the future the MSOT Acuity is a version of this technology without the active ultrasound. The MSOT Acuity Echo is a version with, and so we're working on a multi-center study that will allow us to do both the technical indication first for the MSOT Acuity and in the case of IBD, inflammatory bowel disease, an intended use linked to a particular disease. Along the way as well, we launched the RSOM Explorer, and we're just now as well starting to think about and plan how to move that along the certification as a medical device pipeline. So in terms of clinical translation, I just wanted to give two examples about how researchers have done this. This is data from user Lacey McNally, who's now at Oklahoma State University. What she did in this case was expose mice by oral gavage to a bacteria to induce colitis. She then did both optoacoustics and endoscopy, and she compared the two results. And what she found was that by looking at oxygenation alone, that she would get a very good indicator that correlated very well, as we see down here in the panel C in the graph, where we're looking at mean oxygenation as assessed by MSOT versus colitis severity score, and you see this linear trend between the two, which is interesting that you can assess without the need for endoscopy inflammation in this mouse model. What was done by other researchers here in Germany in Erlangen, and they published now in 2017 in the New England Journal of Medicine, they used a similar approach, but this time it was done in humans. And in this case, they had patients that were assessed by endoscopy. They divided those patients into remission, low, moderate, and high, and then looked at the part of the colon. The foreground in these images is hemoglobin in the pseudocolor, and they're looking at the hemoglobin concentration just in the part of the ultrasound image that shows the epithelium of the intestinal wall. What they found in this case is that the MSOT values correlated very well with the endoscopic score, just like in the preclinical model. When they compared the MSOT performance to other clinical gold standards, the Harvey-Bradshaw Index is a questionnaire, CRP protein is a blood test, and the Limburg score is an evaluation of ultrasound images. They produced these receiver operator curves which compare performance of these different technologies. If you're not familiar with these curves, the perfect version of this curve would be tracking on the left side the y-axis up to the 100%, and then it would make a right-hand turn and go against the top part of the graph. So the closer you are to this upper left corner, the better the performance of this device or this technology for that, comparing to the gold standard endoscopy. What we see in this case is that MSOT outperformed at a larger area under the curve as compared to these other approaches used in the clinic. And this is why we're pursuing this as a specific indication for this technology. So this is a very successful use case of translation of this technology from mouse to man. Second example I'd like to show is in the context of Duchenne muscular dystrophy. I have two slides here, and these are both from the same study that was published late last year in Nature Medicine, also from the Erlangen group. What they did in this case is they had animals, transgenic piglets that expressed Duchenne muscular dystrophy pathology, They then tracked these animals with weekly scanning by optoacoustics in the first 4 weeks of life, and they quantified collagen deposition in the muscles of these mice with the supposition that as the muscles degenerate, that fibrosis occurs and collagen increases. What we can see in the graph in the lower left is the black dots represent the wild type animals where these values were very stable over that month, and we see increasing values in the collagen signals as assessed by MSOT over those first 4 weeks. This was all validated by histology, which was absolutely great. After doing these studies, they then moved into human studies, looking at patients with Duchenne muscular dystrophy. When we're talking about patients, there's a very good reason why you would want to do a non-invasive approach. One of the standard ways to assess these kids could be MRI, where you might need to use sedation. But what they often do a lot is what they call a 6-minute walk test. So some kind of physical challenge where they see how far the child can walk in a certain amount of time. And this is not only, let's say, painful for those children, but also requires compliance. What they did in this case is they had 10 different patients with 80 different measurements in total, because they were looking at different muscles throughout those patients. And again, they saw an increase in collagen signal in the muscles of those patients. What we then see here in the lower right is how on the left-hand side, how the MSOT measurements correlated with these clinical gold standards, either with strong negative correlations in red or strong positive correlations in blue. And we see how there was a very good correlation with these measurements, whether they were looking at using a 3D detector or a 2D detector. So I think this is another good example of how this technology could be used in a translational setting. So finally, I wanted to talk for just a minute about if somebody is really interested in bringing this technology into their lab or core facility, then everything starts with getting funding. Obviously, you have to work on a grant, get the money, and then finally you can get started. The perception, especially when I talk to a lot of people, I've been out of academia now for just over 10 years, but at the time, and still when I talk to my old colleagues and friends, the story that I hear is that the funding lines are very tight. But I actually looked this up this week on NIH and saw that I was a bit surprised by this, but in some cases, like we see NCI at the top with the success rate of 10.5%, but many of these actually have a bit higher success rate. So I was actually a bit encouraged by that, but nevertheless, it's clear that this is a competitive scenario. And especially if the technology is new to you, then that can be an especially challenging thing to do to submit grant applications with the technology with which you're not an expert. So there are mechanisms for this. This is just one possible mechanism that's valid in the US. Hope there are similar mechanisms in different countries. We have one here in Germany called the Großgeräteantrag, so the large equipment grant application. But in the US, there's what's called a shared instrumentation grant, so an S10. The website for the S10 is here at the bottom, and I pulled these images from the NIH website. But over the last 5 years, they've awarded more than 500 of these. The distribution around the US is fairly even throughout the different parts of the US. If we look at the kinds of things that this mechanism is funding, we see both optical instruments and biomedical imagers are, let's say, very common things that are awarded for this. There's interestingly as well, there's no preliminary data that's required for this as well. So I think that's particularly appealing for this kind of mechanism, because a lot of the labs around the world right now, especially in the US, are shut down due to COVID-19. So this is a mechanism that's there. The announcement came just some weeks ago, and actually the due date is June 1st, so that's coming up. But it's certainly a possibility. But the challenge still remains that if you're unfamiliar with photoacoustics, how would you go about writing the best grant application? This is where somebody, for example, in my role as an application specialist or as a team of application specialists at iThera, we offer some support for this process. We certainly can't help with all of it, but there's some parts of the grant where we can certainly help out with. So in terms of working on a project summary or abstract description, we can do this in collaboration with you, as well as work on the project narrative and supply bibliography and references, can help work with specific aims and research plans. So if you're interested in the technology, if something that I've talked about today looks like it's interesting, we could certainly work together if you're interested in working on a proposal. So just to summarize, MSOT is a powerful imaging modality that, as I've shown, is in increasing use. It provides anatomical, functional, and molecular information in real time and also at high spatial resolution in deep tissue. The range of applications spans wide. I've talked about over 50 today, but I'm sure it doesn't stop there. There's new publications coming out every day. We recognize that grants take time and effort, and therefore we also offer grant support. And although the summary that I gave today was, let's say, very fast for some of the applications, if you're interested in more information, please do follow up with us. My email is here on the last slide here. We recently celebrated our 10-year anniversary here in Munich, and this is a picture from our party. But I also put our website on there, and the reason for that is if you're interested in contacting somebody and for whatever reason you don't want to contact me, if you go to our website, it reads the IP address that you're writing from, and on the contact page, it will connect you directly to either the relevant sales director or the distributor that might be working in your part of the world. With that, I would just like to say thank you for your attention and your attendance in the webinar today and your interest in optoacoustics. And if you have any questions and you haven't written them in already, be happy to take any questions now. Thank you.
No, thank you very much, Neil. We do have quite a few questions, so we may spend a little bit of time on this. So I'll read off and start with this. I think you covered this in one of the later slides, but what is the general resolution of the InVision and how deep in vivo can you detect a signal?
So the resolution for the InVision, we have a center frequency of 5 megahertz in that case, and that gives us an optimal resolution of about 150 microns. The depth in that case, when using 5 megahertz, is a couple of centimeters, and because we're doing tomographic imaging, that couple of centimeters really goes from all the edges of the mouse. So that's why we get cross-sectional images of a mouse. We can also, for a rat brain or for small rats, we can see through the cross-section there. For the human case, the publication that comes to mind is one that was done here in Essen, Germany, where with a bit of compression in sentinel lymph node patients, they were able to detect lymph nodes that were as deep as 5 centimeters as assessed by SPECT and CT, but the field of view that they had in that case was a bit closer to 3 centimeters, but they were able to close the distance between the probe and the target in order to achieve that, let's say, 5 centimeter depth.
Okay, and following on, I'll expand on this question myself actually, is so how long does it take to image a mouse? The specific example that's been asked is if I want to look at oxygenation of the kidneys. So how long does it take to image a kidney cross-section?
So one cross-section, one single wavelength, one pulse, we image at 10 hertz, and each of those individual pulses, the image acquisition is in the millisecond regime. So this is very fast. If you want to image multispectrally, if the animal is moving, you may want to do some averaging, or if you do some retrospective gating, you don't need to. But in principle, the fastest multispectral image that we can do is 2 wavelengths at 10 hertz, so it would be 0.2 seconds. More practically, we would probably be doing some averaging, so the temporal resolution per cross-section would usually be in the 1 to 2, 3 second range.
Okay, thank you, Neil. A question regarding the chromophores we can detect. So the question here is, can we really detect collagen?
So this was a good question, and also one that the reviewers were asking in that particular Nature Medicine paper. So they did phantoms in that paper where they showed that collagen was detectable. So that the spectrum was looking just like it should, but ultimately they were asking the question whether the in vivo measurements were maybe partially also showing something related to oxygenation or other chromophores. So the users in Erlangen, they do believe, as I do too, that we can see collagen. And importantly, I think the main thing, at least in that particular application, is that there were very good correlations with the clinical metrics. So I think collagen is something that's new, but it's shown value in both preclinical and clinical applications, but it's certainly something that I think will continue to be validated in the time to come.
Okay, and I'll ask the question and then make a comment, is can you elaborate on the studies of neurodegenerative disease? And I would just step in here and say that actually next week, next Thursday, we're having a webinar by Professor Marty Pagel from Texas, and he's going to be presenting on optoacoustics and MRI, which will also feature some work on neurodegenerative disease imaging. But for Neil, could you elaborate a little bit on MSOT for neurodegenerative disease?
Sure. Yeah. In that particular case, what they were looking at were oxy and deoxyhemoglobin. They did in that same study some co-registration with MRI, and that will be the focus of the webinar next week. But that allowed them to pair the MSOT and MRI information to derive metrics like CMRO2 and OEF and get some metrics that are traditionally used in terms of looking at oxygen consumption in the brain. They then looked at differences in a transgenic mouse model between animals at 6 months of age in that model and 24 months, and they saw decreases in these functional metrics at the 2-year time point.
Okay, sorry, just reading this. You've mentioned a lot of applications that involved hemoglobin as contrast, hemoglobin and melanin and collagen, I suppose. Can you use contrast agents, or is this an issue? So perhaps, Neil, you'd like to explain a little bit about the use of fluorophores and how they're being used in MSOT.
Sure. Yeah, there's a lot of different options. So there's some clinically approved dyes like ICG and methylene blue that are used in the clinic already since a long time. We can see those, although those are not so easy to conjugate to things like peptides and antibodies. There are some dyes. So Lycor, for example, produces a very popular one, IR dye 800. The conjugation in that case is very easy. And as I understand it from going to conferences, they also have a pathway to get that particular dye clinically approved. So there's a lot of options for contrast agents when it comes to optoacoustics.
So for preclinical imaging, I suppose you could elaborate on some of the big publications looking at targeting with fluorophores and so on.
Yeah, that's right.
Yeah.
Yeah.
What's the difference between between tomographic curved array imaging and linear array imaging?
Well, the difference is, I mean, at a very basic level, the difference is the shape of the detector, and one is curved and one is straight. But the difference is let's say the fidelity of the structures that you can detect. So if you're considering a circle, a linear array is going to see the front and the back end of that circle, but maybe not see the sides very well. But a tomographic array has enough projections where it can see around those structures, which I mean, I'm a biologist, but my engineer friends tell me that this provides an additional value in terms of sensitivity and resolution as well. Yeah, I think that would that would basically be the main points.
Okay. Can I do clinical imaging with the Envision? Is the question.
Well, that's interesting. And some users, I mean, they have decided to go for an Envision, but they want to do a translational study, and they don't yet want to get a second dedicated system. So the Envision can be equipped in hybrid mode, which means you can connect some of our handheld detectors to it, the same ones that would be used in a clinical setting. The challenge there is then users would say, well, this has been in a mouse facility, so how would I use this in a patient setting? But what some users have done in this case is it's completely safe to do the hydrogen peroxide gassing of the system, so you can completely sterilize the system and then take it into and out of a facility. It's on wheels, it's very easy to move. I move the systems by myself. I've transported them on trucks by myself, as long as there's a lift, of course, but most people might rather use two people, but the systems are mobile and it's certainly possible.
Okay, thanks, Neil. One question about grants. How many users do you need to have for an S10?
That's a great question. So the short answer is more is better, but the minimum is 3. So you have to have 3 R1 funded researchers who get together and make a case for using this equipment. But the more competitive applications then are going to have 6 to 9 users in that case. And that's also something that we can help with in terms of identifying who might benefit based on what they already do and how MSOT could maybe provide value in that particular case. We can help with that brainstorming.
Brilliant. Thank you very much, Neil. There's a few other questions, but I think as time is moving on, we will address those separately. And what we can do is answer those questions to you directly. And as mentioned, we will put this webinar on YouTube very shortly, so you can come back. So we'll let you know when that's up. And as I mentioned, we are going to be doing another webinar next Thursday, which we'll also send you some information about. So again, thank you all for taking the time to attend today. And thank you, Neil, for a very nice presentation.
Thank you, everybody, for joining and for the questions.